Okay, so for this class, it's going to focus on critical care. This is kind of just like again, just a breakdown on what kind of patients, I guess, will be the bigger focus on. So for the most part, it's going to be patients who are very unstable. They're going to be having issues with their ABCs, which is why they're going to be in the critical care unit. So that includes people that are septic, respiratory failure, acute instances of DKA or HHNS, um, post-op with like major surgeries like a Whipple or with like a post cabbage, people that are going through like acute burns, trauma, or electrolyte imbalance. Okay, and then I have like a few little points here, but you don't have to like memorize any of that. They'll go over into like detail on all of this stuff throughout the semesters. Oh, not semesters. Throughout the weeks. So you will have a session on all of these, right? Um, so this is just for information. You don't have to hard memorize any of this stuff right here. The focus will be um, more on some of the for the first quiz that you'll have will be more on some of the other stuff down there. So don't worry too much about specifics on all these. That will be gone over later. Something I do think is really good and important is this CAM scoring. I think it was a slide that talks about it. It's just when it comes to like acute confusion, this is an acronym that I think is pretty good to kind of think about why some of these things can happen. So the T for toxicity, that could be something like, you know, drug overdose, aspirin overdose, like Tylenol overdose, um, digoxin toxicity. So pretty much just like drugs, digoxin, etc. Hypoxia, they want you to really get like in your head that if someone's acutely confused, you have to rule out their SATO2 being really low. Infection, something that they've been hammering down is that especially the older people, when they have infection, they can get confused. And non-pharmacologic reasons is just kind of like a blanket one just to make the acronym work. But it includes things like dehydration, severe dehydration to be specific, severe hypoglycemia, a thyroid storm, and then the K is for potassium or electrolyte imbalances. Okay. And then I have this short section on central line. So overall, we're gonna go over through the central line review, and then it'll be on this little section on hemodynamics. And I think the major focus is really on the A line here, at the central line, and then your VAP bundle. As for the Swan-Ganz, all that specific stuff on Swan-Ganz will be not for the first quiz, but for the quiz after that. Okay. So as a for review for the central lines, just to go over real quick, for the central lines, they go pretty much directly to the heart. So they're using that for things that are either too, um, things such as vesicants, so that it doesn't extravasate as easily, longer term chemotherapy. If someone's going to be sent home with antibiotics, IV antibiotics, they'll probably get DC with like a PICC line. Sometimes if they're really difficult to get a stick on, get a peripheral stick, they'll either do ultrasound guided or they'll just put in a PICC line. Or the TPN that we learned about last semester. So here again, just a quick review for non-tunneled, and then remember that in the skills lab we should still have that mannequin that lets you kind of see them. So the non-tunneled, this is a shorter term one, and what's it used for? In term, not like a specific thing, but like when would you bust this one out?
An emergency, like when you really have to do it in the
Yeah,
ER.
yeah, it's pretty much just like you gotta get it done. You just kind of go for it. It's very, as you can see here, from where it starts to like where the heart is, it's just kind of in and then done. It's not fancy. It doesn't have anything fancy. It's just there so you can get a central line in. Um, don't need any surgery or anything to remove or to place. So you can get this one done quickly. But this one has a higher risk of what?
Infection
Yeah,
as well.
infection. Hmm. Oh, and then what else were you gonna say? Jingle?
I don't know if I'm saying it right, but pneumothorax.
Yeah. So the pneumothorax as well. So this one you're just kind of going crazy and just putting it in. So you have the risk for infection because it's kind of like think of it like the um like but pretty much you're putting in something invasive, so there's always that risk for infection. But this one's less fancy, more just kind of put it in, stick it in and forget it. So higher risk for infection. You have that risk for pneumothorax because anytime you're putting it in this um, vein over here, there's a chance that it might poke down to the lungs. So what would you need after that to kind of rule out that you accidentally pneumothorax someone? Yeah, so a chest X-ray. So you basically put that in, get them the quick chest X-ray to make sure that there's no both check for positioning and then make sure there's no pneumothorax, and then you're kind of good from there. So this one's super short term emergency, get it done, short term, and it's the least fancy of them all. And then we have the tunneled, which is pretty is the main thing you'll see with this one is that you will have the exit site where like the little tubes are considerably further down here, and you will have this little like sleeve where the tubing is underneath some of that subcutaneous fat. So this one is actually surgically inserted. So it will need to be surgically inserted and surgically removed. So it's a lot fancier, which allows it for a lower risk of infection because now there's a much longer distance for if there's any bacteria for it to actually travel if it were to come from here. Plus, there's that disconnect between the fact that the actual insertion point is here, right here still, and this is part is just like surgically placed underneath the fat. So the insertion site's actually right here, but this is where the exit is. So there's this whole sleeve of protection, and it just makes it a lot less likely for infection to happen. And therefore, this one's there if you're expecting it to be a bit longer term because you went through a surgery to put it in so that it could last longer. Same thing though, because you're still inserting it at this site, it will need a chest X-ray for the risk of pneumothorax. And this is the shorthand for pneumothorax. Okay. If there's any confusion still, again, refer to the mannequin that has that shows all of the catheter central lines. So you can literally feel the sheath underneath and kind of see all the different ones. Next one up is the pick line. So with the pick line, this one is again for a little bit longer, usually for a little bit longer time that you're going to want it going. Uh, would you like a chest X-ray for this one still?
Yes.
Yes. What about the risk for pneumothorax on this one?
I don't think it has a risk for that.
Oh yeah, that's right. I already wrote that there. Oh yeah, but yeah, there's not as much risk because just the way it's inserted, it's peripherally inserted. So because the poking doesn't happen anywhere near the lungs, it's not really there's virtually no risk of that, but you still want to do the chest X-ray to confirm it. So essentially, all the central lines will require a chest X-ray just to check for placement. Similar to your NG tube, you're just doing it for placement. And then this one has like a unique little thing. So there's something that you want to be measuring, and just to sure external length. Sure, we'll include that in there as well. So we will include that in there. So you can measure the external length, um, just so that you can keep it consistent, so you know if it's been pulled out or if it's been pushed in. Is there anything else that you can measure as well? This one specifically to assess for clots.
Oh, you're gonna measure the arm circumference to make sure it's not bigger than the other arm. Like we have to compare.
Yeah, so you're gonna measure the arm, allegedly. I don't think I've seen people do it, but I've never seen a single person do it. But yeah, you're supposed to do that just to assess for clots. And then for the external length, just remember that if it is pulled in or pushed in, you're allowed to pull out, but you're not allowed to push in if it's pulled out, if that makes sense. Uh, two. Okay. And then something that if you've had a patient with a PICC line, you'll see that they have like the no BP on arm. They probably have like a sign that says don't do BP on this arm, or they have a bracelet that says don't do BP on this arm. So you don't wanna be doing their BP on their arm. And then they should be mindful of arm movement and exercise and lifting. So just because you don't want to just ruin the integrity of the line or increase like the risk of like a clot or anything. And then the last one is the implanted. This one's more common with like patients that need chemotherapy. So this one's you can take a look at the picture, implanted central line. So kind of looks like that. So have this little thing sticking out. Uh-huh. You'll need the non-coring Huber needle to access it. It's obviously requires surgery to put in and to remove. And then this one wants you to be flushing it with heparin to prevent clotting. So usually for cancer use or chemotherapy or any super long-term use needing to be used. Any questions on the central lines? And then I have this quick like complications thing. So for the most part, the main thing you guys are really going to focus on is going to be probably mostly on the complications, considerations. Uh, Definitely going to want to know to do like the chest X-ray. Going to need to know about measuring the arm. the risk for pneumothorax, all that stuff is what you're gonna want to keep in mind. Okay. So some of the things I included in here. So for your complications, does anyone remember some of the signs and symptoms of a pneumothorax?
Shortness of breath,
Yeah, so some shortness of breath. I'll include dyspnea with that.
low O2 sat,
Sure, yeah, like sure. Put like hypoxia, I guess. Tachy. So it's usually like well, hopefully it's usually like unilateral. So would there be a difference between both sides? Like if you listen to the right side versus the left side? Yeah, so it'd be like decreased lung sounds on the affected side. And then it might also come with some pleuritic chest pain, which basically means chest pain when you're breathing. So that's pretty much it. It's kind of vaguish, but shortness of breath, uneven chest rise. I feel like that might be, yeah, I think that can happen as well. Uneven chest rise. Yeah, so uneven chest rise, I think especially if it's like a tension pneumothorax. But don't worry about tension pneumothorax as much because they don't test on it. Um, and then there's air embolism, which has very similar symptoms. So again, like the tachypnea, the slash dyspnea slash shortness of breath,
Chest pain.
chest pain. So basically, this almost the same symptoms. But you know, you'll be able to kind of tell based on the usually from like what happened. Like, right, it is possible technically to get like a spontaneous pneumothorax. From what I've seen, or not seen, but like from what I've read, apparently, tall, lanky people are more likely to just like spontaneously get a pneumothorax, like out of nowhere. I'm not sure why, but apparently that's a thing. But usually this will be following something maybe kind of obvious. So like if it happens right after you are removing the central line, like with these symptoms, it's just using the context clues, you'd be able to tell. And then do you guys remember what you should be doing to when you're removing the central line? So let's say you're gonna be pulling it out. Any instructions that you give to the patient so that this doesn't happen, I suppose. Yeah, bear down, hold your breath while it's getting removed. Don't talk, don't laugh. Basically, bear down, hold breath, don't talk, don't laugh. Hmm. Pretty much that. We talked about the thromboembolism, measure the arm, flush frequently. So this one that you're definitely doing like a nice big flush. And then the CLABSI, remember that when you're doing your central line dressing change, you'd use the chlorhexidine and you're doing all that stuff with that. If I recall, that was last semester, right? The central line dressing change. Okay, cool. He does have this acronym, which I do think actually comes up. Does anyone remember any part of it out of curiosity? I recommend actually knowing it just because it'll actually come up. Yes, scrupulous. Hygiene. Ha. Aseptic technique. Yeah, ensure patency here. And V will it's a vigorous friction to hub. Basically scrubbing the hub. Make sure you're actually scrubbing being aseptic, scrupulous hand hygiene. And then for another complication could be arrhythmias. And this one's just based on the algorithm, which again, that will be more relevant for next week or for week 2 rather. And then some nursing considerations here. We talked about chest x-ray pretty much always to confirm placement or assess for pneumothorax. Aseptic technique is going to be, consistent throughout. And then something I mentioned before here is if the catheter is pulled out, we cannot push it back in. But if the catheter length is shorter, so it got sucked in somehow, we can pull out. All right, so that's kind of your kind of guideline there. The dressing changes, it's every 7 or as needed. It uses a transparent semi-permeable membrane. So not a gauze dressing, it uses a transparent semi-permeable membrane. So if there happens to be something where this comes up, it's a transparent semi-permeable membrane. And not a gauze dressing. It is a transparent semi-permeable membrane. Okay. Other things that might come up is actually I guess it would actually be for the next upcoming thing. But yeah, that's pretty much it. Any questions on the review of the central lines? Okay. So here, this one's like a short section on hemodynamics, going over the Allen test, the A line, a little bit on the Swan scans, but just remember that that's going to be more of a focus for week 3 and not so much week 1. So yeah, and right here they have like this little thing which has like your heart rate, your SATO2. It's gonna have your arterial pressures. your pulmonary arterial pressures, central venous pressures listed, the respiratory rate, your PaOP slash PaWP. Don't have to be able to pick each thing out from here. This is just like an example of the stuff that it includes. And then all the little waveforms here. If you guys had that in-person class with Miss Brooks, she probably made you guys do the Allen test on each other, if I'm guessing.
Yes.
Yeah, so if you guys, just because you guys got to do it in person, I feel like that sticks a little bit better. But the main thing is that the A line is going to be very typically placed on the radial artery. So the point of the Allen test is that you are blocking off both the radial and the ulnar, and then letting go of the ulnar. So you're only clamping down the radial to kind of make sure that the perfusion with just the ulnar is good enough. That because you're going to be again blocking off that radial artery with the A line. So it's just to check to make sure that the ulnar is going to be good enough to perfuse the hand. Hmm? Okay. So looking at this picture again, this is your radial right here, and this is your ulnar right here. So you're clamping off both with your hands until it turns white. Pump a little bit, and then let go of this ulnar. So you're only clamping down here where the catheter would be. And as long as the reperfusion is good, you're able to put the A line in. So the purpose of this arterial line is that it is a continuous way. The important thing is it's continuous. It's a continuous way of monitoring the blood pressure as well as an easier way to just get arterial blood gases because you can just get the blood out directly. It's already connected in there, so getting the blood out is easier than doing like a one-time stick. So this will give you, your systolic, your diastolic blood pressures. It'll give you your map, which for you will need to again remember this formula. It'll still come up. So this formula is still important for you to have in your head. So your MAP will be 2 times your diastolic, and then add that to your systolic, and then divide the whole thing by 3. Okay, so you'll still need to do this during your test. So keep that in mind. Uh, so it'll also give you your heart rate and then have that wavelength still to let you know that it's a good reading. But yeah, it's basically like having continuous all of that continuously, which is nice. I think not necessarily placed on for all patients in the ICU, but if someone is there someone that needs to have all of this stuff continuously monitored, it'd be nice to have. So some of the benefits here, because it's continuous, that makes it a little bit easier to titrate the vasopressors because you can see the real-time effects of the titration. Um, Continuous flushing, either with heparin or normal saline. And then some of the things to keep in mind here is that you want to have a splint for the arm slash the wrist. So that's going to be an important thing to keep in mind, just so that there's a minimal amount of movement that could block off line or do anything like that. So splinting the wrist to minimize the movement is important, as well as keep it in position just so you don't mess with the integrity. So if you do, you might have to readjust and recalibrate it. Here's like a picture example. It never gets too deep on any of this stuff here, by the way, guys. It's just basic. It's like basic ideas on the A line. It's never too crazy detailed on any of this stuff here. With like the fluostatic axis or all that stuff. It's not going to be super in depth because this is not even though this is technically like the critical care class, it's not like a CRNA class, so it's not too deep. So don't go too crazy on like memorizing everything that's in this picture here or like learning all that stuff. That's too much info and don't overwork yourself on that. So just keep in mind, especially with the Swan scans, because I know that I think, put a video like a ICU Advantage video, I think on the Swan scans, and that one goes into like hyper detail on it, and you're not going to be tested on all that. So that is more like a video for people that are going into the ICU and will need to know that versus you who is just taking this class and will not need to know that the the yellow and the blue and the white catheters do this and that. Yeah, so it's just the superficial stuff. So really just knowing the considerations and the purpose and all that stuff. Nothing hyper specific. Yeah, I figured. I did the same, but I had a feeling. I remember I had a feeling. I'm like, there's no way they're gonna test us on the colors. But and yeah, you don't just outright telling you they don't test you on any of that. No, don't worry about that. So complications, you can expect there to be bleeding because it's an arterial. It's going into the arterial. Um, Kind of stuff that you can kind of expect, right? So bleeding, infection, clotting, the embolism because you're putting it into the arterial, so air embolism or just a clot going into becoming an embolism, a hematoma from inserting something. All of these are pretty straightforward, makes sense. Any questions on the A line? Oh, I think a important thing I actually somehow skipped here is that you still want a blood pressure cuff. I think a manual one. You want it like a manual blood pressure cuff at the bedside for confirmation, and you'll be putting on the opposite arm as the A line one. Just so that you have confirmation if the blood pressure is like really bad on the A line, just to confirm. That way, if it's something off with the machine or something that needs to be recalibrated, you have a way to check against it. And then the Swan scans, just kind of seeing what we need here. Yeah, the Swan scans again, don't go too crazy on any specific details here. Here's just like a picture of what it kind of looks like. So the Swan scans, otherwise known as what is the other name actually? Yeah, the PA catheter, the pulmonary arterial catheter. Um, that one you'll see it in the yellow, so that will be the yellow. So it's gonna go down here, all the way up here, and this right here will be like a balloon that's able to uh, inflate, and then that's how you get your the pulmonary arterial wedge pressure, also known as the occlusive pressure. So you'll either see PAWP or you will see PAOP. Both are the same thing. And there's this whole complicated little thing where uh, you can differentiate between a bunch of different things, a lot of different pressures in the heart. For the most part, the main things you will need to really know, I'll go over and kind of differentiate that for you. But the purpose of it, like I mentioned here, evaluating patients with different cardiac circulatory disease processes or shock states. So one of your big things for the test is going to be this CVP, your central venous pressure. So the CVP is, I have it kind of written here. It is essentially your right atrial preload, or basically the preload at the start of the heart. It's basically the pressure that is going to go into the heart. So it's that pressure that's coming off from your body up to the heart. That is, remember, the preload is the pressure, pretty much the pressure of something, the filling pressure, and then that's on the right atrial because this is coming from the body, which is why it's central venous because it's coming from the body up to the heart. So it is the pressure coming from the body to the heart. Okay? So it's basically what you have, it's what your heart has to work with because once it gets to the heart, that's when the pumping starts. And that's when the pumping, getting the O2, uh, getting the O2 in there and then pumping back to the body kind of comes in. So with this, the numbers you'll want to know is 2 to 8. That's the range, normal range. Whenever it's considered low, and this low can include just being on the lower end of things as well. So it's not like it's a little bit more nuanced. So it's like if you have a 2, like if you're at 2, you think of it like closer to low. Like you're gonna think of it like you're gonna start thinking here basically. So even though it's still within quote unquote the normal range, you're still thinking along the lines of this, right? If it's low, you're considered dry, um, which means you need fluids because you don't have enough. So again, this is your pressure leading up to the heart. So if it's low, that means your body doesn't have enough circulating to build good pressure. So if this number is low or on the lower end of normal, you're considered dry and you want IV fluids. If this number is high or on the upper levels of this range, that means you have too much pressure, too much fluids, and then that's when you use your diuretics or your fluid restrictions to try to fix that out. Okay. You also have a pulmonary arterial pressure, which is different from your pulmonary arterial wedge or occlusive pressure. This is pulmonary arterial pressure. You don't have to really know for this class, but just for the sake of completion, it is the pressure going into the lungs. Okay. And then kind of more accurately, probably as accurate as kind of like the pressure in the lungs, if anything. So this is the pressure in the lungs that your right side of the heart has to fight against to push that blood into the lungs. So if you guys have heard the term the pulmonary hypertension, that can be measured with this. But again, you don't need to know the value of it or any hyper specifics about it. But that's where that idea comes from. So, and again, if you guys do recall about pulmonary hypertension, you would maybe remember that some of the complications of that include right-sided heart failure, which makes sense, right? Right-sided heart failure is also called cor pulmonale. So cor meaning heart, pulmonale meaning related to the lungs. So that makes sense, right? Because if like think of your heart. So imagine this is going towards the lungs right here. If you have a lot of pressure build up in your lungs that your right side of the heart has to push against to make it to the lungs, and this pressure is really high, eventually it's going to struggle to pump it out to the lungs. So it's going to start backing up in the right side of the heart. Hence why pulmonary hypertension leads to right-sided heart failure. That's why your COPD patients have a higher risk of right-sided heart failure and uh, a chance for all that stuff to happen. Does that make sense?
Yes. Yes.
Okay. And then the value that you will also want to know is going to be your PAWP, your wedge pressure slash occlusive pressure. And it's also known as your left ventricular end diastolic pressure. So it has a lot of names, and they might have thrown all of these acronyms out at some point. So if you were confused, I don't blame you. But this value here is essentially the pressure in the left ventricle. So the pressure, right, that builds up in this left ventricle before it gets pumped out to the rest of the body. So this is an important, it's important to know this one because this is the pressure that your body's going to use to pump out to the rest of the body, or your heart's going to use to pump out to the rest of the body. It is your preload of your left ventricle. You are also going to need to know this value. So you're going to need to know this 2 to 8, and you're going to need to know this 4 to 12. Okay. I think for the hyper specific stuff, or I think for like I'll still know the values, but I think for the first quiz, it might focus a bit more on CVP. And then maybe for your future test slash quiz that includes hemodynamics, that's when they'll focus more on the PAWP. But yeah, so here I've listed like the four main pressures of the heart here. Your PAWP, so this left ventricle, the pressure here is fighting against your systemic vascular resistance, which is the afterload. So that's the pressure that's built up in the body that your left ventricle has to fight against in order to pump out to the body. Your heart has to pump against to pump out to the body. So if somebody has really high systemic vascular resistance, which would be the case if someone's like really clamped down, like their body's really clamped down, your left ventricle is going to struggle to get blood out to the body, which then leads to it backing up and then leads to pump failure. So if somebody's really clamped down too much, that pressure is too much for the left ventricle, and then you don't get blood out. Which is relevant because sometimes, and you'll probably go through this like a little bit later on in probably like an in-class activity where sometimes you can improve your heart function by basically if someone's on like vasopressors, sometimes titrating down the vasopressors will actually improve your blood pressure. Because it's going to decrease the systemic vascular resistance, which then allows the left ventricle to actually get blood out, if that makes sense. So sometimes you clamp down too much, you ruin your ability to pump out blood to the heart, and then your pressure suffers because the pressure is actually so high that nothing's getting out. So at the end of the day, the pressure that's actually leaving the heart and making it out to the body is low because there's barely anything coming out. So sometimes decreasing your titrating down your vasopressors will help your blood pressure because if it's too clamped down, nothing gets out. Does that make sense?
Yes, no, that makes sense.
Hmm. So that's where it gets really nuanced, and why hopefully if someone works at the ICU, they get paid more than someone who doesn't. Because titrating all this stuff is very nuanced. It's not black or white. It's a lot of critical thinking on it. Like it's not just blood pressure low, increase basal pressures. You have to think about if they're clamped down too much. You have to think about if especially with like some of the like norepinephrine and stuff, like assess their extremities. If it's starting to get dusky, then you clamp them too much and then they're not getting enough circulation in their fingers and then all that stuff. So it's a lot of nuance. Okay. And then there's this one, this comes from the video partly. I don't, this thing is just kind of like a basic idea, but you don't need to know the hyper specifics about it. This is for cardiac output. So one of those flush lines, I think it's the blue one. It doesn't matter, but I think it's the blue one. You're able to pass fluids through it, and the Swan scans has a way to measure the temperature of that fluid in order to kind of estimate the cardiac output. So the idea is naturally your heart working is going to heat up that fluid. But if there's a lower change in temperature from when that fluid passes through the line and makes it to wherever the little thing, that little thermostat that's in the catheter is, it means that it passed too fast for the temperature to change, if that makes sense. So you push fluid through, makes it through the thermometer. Um, the better the cardiac output, the faster it makes it through without changing in temperature as fast. If you have worse cardiac output, then that fluid is taking longer to travel, so it has a longer time to heat up, if that makes sense. So that's another thing that you can do with your Swan scans.
I know some of them, it's still old school where you push the hi, where you push the fluids through, but then they have some that have that like the thermometer on the inside and it
Oh,
constantly
on the
does it
inside, that's cool.
because they're in I know this is extra information. Oh geez, you just smacked me with the mic. This is kind of extra information, but with your swans you have all those different little ports coming out of it. Then you have the one that you can put fluid in to check your thermodilution, check your temp. But newer ones are able to consistently monitor, so you don't have to do that anymore because it's very oddly specific. Okay. Hi, Jingle.
Okay. So some special considerations. The Swan scans is inserted through a central vein, which makes sense considering, it has to make it through all this stuff. Another important thing that you do need to kind of know, and I believe Mr. Robbins mentions it through his video as well, is that it needs a specific like 3 ml syringe for the balloon port, because anything different from the 3 ml one can have a different pressure. And you don't want to mess with that stuff if you're pumping a balloon that will directly like block off perfusion from your heart. So it's a 3 ml syringe, and it's 3 ml so that it has a specific pressure when it's inserting, but they don't want you to infuse more than 1.5. Oh, Kaylin says there's actually a fail safe on it, so you physically can't. but so you can only get 1.5 mLs in there. It is 3 mLs, just the syringe itself is 3 mLs, just so it has the right pressure. But yeah. And you do this, you do this to get the pulmonary arterial wedge pressure. So that's this balloon right here. So the basic idea of this of doing that is that it lets you estimate the pressure in the left ventricle. So effectively, the way it works is um you are blocking off this piece right here, like everything before it is now blocked off, and you're able to measure the pressure that is about to go into the lungs, okay? Because the pressure that's about to go into the lungs is approximately the pressure that will make it to the left ventricle. So that is the idea. Don't have to know the hyperspecifics, but that's the basic idea. Is you're pushing this balloon out so that you can single out the pressure going into the lungs, which will be an estimate of the pressure because again, it goes from lungs back to the left side of the heart. So you can estimate the pressure that's about to go into the left ventricle so that you can have this preload of the left ventricle measurement, this 4 to 12.
So when do you read it though? When the balloon is deflated or the
It's read when you inflate the balloon. So you inflate the balloon, it gets the reading, and then you deflate it because you don't want them to, yeah, because you don't, you don't want them to die. So,
oh,
uh,
okay.
yeah. So it's the pressure when it's occluded, hence why it's called an occlusion pressure, or slash the pressure when it's wedged. So wedge meaning balloon up, occlusion meaning occluded. So you get this balloon up, it gets you a reading, and then you deflate it. And then that reading is the estimate of how often can you inflate it? I don't really know how often you can inflate it. But it's also not asked, so but I honestly don't know the answer. Okay. So Kaylin's saying that she's looking through her ICU book. She's saying that every couple of minutes, and then you take the average of 3 readings. So you do it 3 times with like a few minutes of rest time, and then take the average, I guess.
Okay, that sounds
Mhm.
good.
And then here's just like a quickie of values that you want to know. So the main thing, your central venous pressure that we mentioned, they're 2 to 8. Your wedge pressure, which is 4 to 12. And then your cardiac output. You should know cardiac output is the stroke volume times the heart rate. It's 4 to 8 liters per minute. And then there is this acronym here that you could use. It's called CRAP. And these are all the things that maintain your cardiac output. So your contractility, which is how strong you're pushing through, the rate, and then the afterload and the preload. So you can kind of see how this all 4 of those relate to either the stroke volume or the heart rate. But yeah, you can see here how messing with the afterload, messing with the preload is going to affect the cardiac output. Improving the contractility, so how powerful your pumps are, is going to be affecting your cardiac output. Hence why some of your medications that we'll go through here really quick improve contractility, so they're used for improving cardiac output that way, etc., etc., etc. But is there any questions on swan scans? Because I know it's a lot. I'll we'll go into more detail on it. I think week 3 is when it really when it goes into more detail, or at least when it's tested. To be honest, the most really that you're using it is just interpreting the based off the number more than anything. Okay. So only a few more, and then I do have like a few questions for us to do together. Here, for your IV medications here, they go into more detail again on week 3. So I think right now we're really focused on probably week 2 because it's really long, right? The EKG. But honestly, your week 3 is more important. Your week 2 is a lot of content. It gets a lot to go through, but it's really not that many EKG questions. The IV meds, no. It's just here for context. For the most part, it's just here for context. You'll go in more detail over week 3. Yeah, just so you have a basic understanding of these before you go into week 3, because I think week 3 is the bigger focus. So obviously your quiz 1 is only on week 1, and then your week 3, the next quiz that you do is week 2 and 3, I believe, combined. So it becomes it's a very heavy focus on week 3 with some EKG interpretations, but the majority of your focus should be on week 3 actually. And the EKG is just very basic application application of it. So I do have some. I'll give you guys the material for that as well. It's basically just like the between the basics and the algorithm interpretations. I know they go over a lot of detail, like about like the difference between the R wave and the difference between you don't really have to go that deep into it. When you're reading EKGs, you're honestly like when you're at least maybe it's different in ICU, but when I was reading EKGs, I was literally spending like 3 seconds looking at it and then putting the interpretation in. But yeah, so here's like the basic rundown. So your big thing is gonna be your norepinephrine. This is like your go-to. It's gonna, for the most part, the main thing it's gonna do is increase the blood pressure. Okay, so you can see like a little bit of pattern. So you have norepinephrine, blood pressure up mainly. Your epinephrine is mainly going to be your heart rate. It can increase your blood pressure at higher doses, but you're thinking of more heart rate with epinephrine. So you have kind of like your blood pressure specialist, your heart rate specialist, and then you have dopamine, which can increase both. Okay. For your inotropes here, you will have the common thing here is that your contractility goes up. On their quiz 2, yes, yes. But week 3 will have these in more detail. So this is just to get like a little overview. So when you see it again, you kind of already got introduced a little bit to it. Yes, so inotropic basically means stronger contraction. Yep, that's pretty much what that means. Because that contractility, I think because the contractility is due to, you know, the your changes in your potassium and sodium, your sodium potassium pump, which are ions. So I think that's where that word comes from, inotropic. But yeah, contractility up with all of these. Your dobutamine makes the heart rate go up. We know digoxin already. We know digoxin makes the heart rate go down. So that's the one that makes heart rate go down. And there's a new one that you guys have probably haven't seen yet. It's the milrinone. This one will make your heart rate go up, just like the dobutamine, but it will also make the blood pressure go down. And again, more details on week 3, but that's the basic gist of it. Again, don't have to hard memorize this yet. For week 3, you'll need to know it a little bit better, and there'll be a bit more detail, but this will get you the general idea of it. So norepinephrine is your blood pressure specialist. Your epinephrine is mostly for heart rate. Your dopamine does both, but it does both, but it's more chaotic, so it's kind of harder to mess with. And then for the inotropes, we already know digoxin is stronger pump, decrease heart rate. So that one we don't really have to learn. It's just like a review. The butamine is a newer one, I'm sure. For the butamine and milrinone, I think are newer for you guys. So the butamine is just heart rate up. Milrinone is heart rate up with blood pressure down. And then you also have some antiarrhythmics. So some of these things you can see B drips, cardizem drip, lidocaine drip, nitroglycerin drips, amiodarone drips. So I know it's a lot of stuff here. And you don't have to go hard detail on the, especially these ones. You don't get quizzed. You don't get tested on heavy detail on any of these at all. I would say this is like extra info here. Okay. Now there's this little bit on mechanical ventilation. I think your main focus is going to be on this VAT bundle, but we'll go through the mechanical ventilation right now. Again, this one is going to be in more detail. I think either week 4 or 5 for you guys is the ventilator topic. But some of your considerations, this should all make sense, right? If someone's being ventilated, you were caring about how often they're breathing, how much effort they need, what do their lungs sound like, what's their O2 sound like. So basic, that makes sense, right? Something else that is good to keep in mind, pretty much everything that's highlighted is good to keep in mind. There's an end-tidal carbon dioxide monitor. So it's the amount of CO2 that's released at the end of a breath. So that's going to be something that you use to kind of determine pretty much the placement of it. So it kind of helps you know how much is being released. It's another thing that gets kind of monitored. This thing gets strapped on, taped on to the mouth. So where on the lip is it? You're cleaning around it. Basically the location and placement of it on the mouth. The settings is what they're gonna put into more detail when you guys get around to it in the week 4 or 5, I think it is. Patients are going to be sedated, hopefully, and then placed on restraints just because it's pretty common that they'll wake up, they'll freak out. If they wake up, they might freak out and then try to pull it out, which you definitely don't want. So that's why they would have like wrist restraints. And then the big thing is just making sure you have your emergency equipment. So having the ambu bag if they need to be rescued and suction, just in case. Just on like by the bedside so that you're good to go in case something happens. Um, any questions so far? Because I know we went through, what did we went through? We went through these quickly, went through the IV meds and the ventilator stuff. Pretty much everything that's highlighted or bolded, try to think, just make sure that you remember or think about. Now, for this VAP bundle, I want you guys to actually like genuinely kind of memorize this. Okay? And I want you to remember this one, like specifically, including the frequencies. So you should know oral care is every 2 hours. So every 2 hours, right? So if you have a choice that says oral care every 8 hours, you do want to do oral care, but you don't want to do it every 8 hours, so you don't press it, right? Because it has the right idea, but the wrong frequency. Okay? So oral care every 2 hours. The suctioning on the ET2 is as needed. And if you have to put a frequency to it, it'd be like every 2 hours, but it's as needed. You're going to follow all your DVT prevention. So having SCDs, the heparin, um, all that stuff, Ted hose. Head of the bed elevated 30 degrees or higher. This one's maybe slightly random, but it's prophylaxis for like acid reflux. So that you don't have, if you do have acid reflux, it's not kind of being refluxed out and then going into the lungs or anything like that. So that's the reasoning for that. Yeah, and stress ulcers and all that stuff. So you have your PPIs, like your omeprazole, pantoprazole, and your H2 blockers, like your famotidines and all that stuff. You also have something called a sedation vacation, which is essentially just getting them off sedation or just interrupt the sedation for a little bit to give them a chance to do things um, a little bit more on their own. Because the goal of the ventilator is stabilize them and then slowly allow them to be weaned off. So at the end, the goal is to get them off the ventilator, right? The RAS, um, what do you mean like hard memorize like the whole scale? No, you don't need to hard memorize it. You will use this, but you don't have to like hard memorize it. You might be using it in one of your in-class activities, but it's not like a hard memorization. Yeah, so Kaylin said if you can hear, probably not actually, but but yeah, negative means they're sedated and positive means they're awake slash agitated. So you want them to be negative if you're sedating them. So if there's like a propofol drip or something, you have like instructions to keep them at a certain RAS level, but you're not hard memorizing the RAS. Okay. So I guess that's more than I thought. 14 questions here just to go over. And then I'll try to answer as many questions for EKG, and I'll give you guys some of my little fact sheets on it, because I know it's a lot of content, but you can actually really summarize it down pretty fat, like to like a short amount. Like you can keep it short. And I highly recommend Nurse Sarah video on the EKG. She'll make it a lot easier. And again, I recommend that you go on. Oh, I guess I don't have it here. The AHA and do some of these. Maybe even do the pre-course self-assessment for the ACLS. If it lets you. Yeah, let's do some of these. So, these should be pretty easy. Number one, you are a nurse in the emergency department, and you're assigned a patient requiring an emergency central line insertion. What central line would you place, basically? So remembering what we talked about. Yeah, so we're gonna do a non-tunnel because that's the emergency one. It's quick, easy to put in. Subject of, like relatively speaking, I'm sure it's not easy to put in, but it's relatively speaking the easiest one to put in. Yeah, so this one's gonna be the non-tunneled. And then when I give you guys the file, the answers are gonna be down here. Okay? So you put in a non-tunneled central line. What are some of the complications that could occur? Pneumothorax. Nice. Okay, so we got that down. So here's a multiple choice. You are preparing to transfer patients from your emergency department. Which of the following patients should be transferred to the ICU first? Just remember that you'll still have these like prioritization questions throughout your test sprinkled in. A 30-year-old male with minor head injury, a Glasgow coma scale of 15, a 50-year-old female with stable vital signs, recent diagnosis of DVT awaiting discharge, a 70-year-old female with acute respiratory failure requiring high flow oxygen therapy, and 45-year-old male with hypertension with chest pain. This should be pretty simple, pretty simple. So yeah, it's gonna be the person with the failing ABCs. So for your Glasgow coma scale, 15 is actually the best it could be. It's out of 15. So this person's fine. He'll walk it off. This person's about to get discharged, so they're fine. And this person has some chest pain, but they don't necessarily need to go to the ICU yet. They will probably just get laps drawn. This EKG, rule out a MI, go from there. Okay. I guess it's a vague ass question, but this is just what is your role in the ICU? Kaylin said these are her questions, so she said she was struggling. Yeah, it's from a year ago. We'll just go over it because this one's kind of vague. Yeah, just it's a lot of it's a lot. ICU is going to be a lot of assessment, like a lot of assessment. They will have a lot, like even though you only have two patients, you're doing a lot of stuff for these two patients, and you're doing it very often. So your goal is really to really follow the nursing process really truly trend everything, assess everything, truly trend everything. Um, work like you're gonna do a lot of stuff basically. You're gonna be trending, you're gonna be assessing, you're gonna be titrating, you're gonna be contacting the doctor for a lot of stuff, I'm sure. You're gonna be doing a lot, to be honest. And you're gonna be doing this with a patient that's probably sedated and can't respond back to you. Which for some people that's a plus. Yeah. Yeah. So Kaylin was saying that's why your assessments are extra important because they can't tell you anything, they can't communicate. So you're really gonna have to be good at all that stuff. Number five, these patients require some special, oh, pretty much what we just talked about. Um, yeah, I'm just gonna include this because this one's vague. Assess for pain, agitation, delirium. So pain and agitation, agitation can, be quantified with the RASS scale. Pain can be done. They have a few scales for like nonverbal. Delirium, we talked about our think acronym. It kind of just goes from there. Skin breakdown could be like a Braden scale for pressure injuries and stuff. Yeah, and one of your big things is just making sure there's all emergency equipment is available. So some kind of stuff that we touch upon when we're doing like our simulation scenarios. Like if somebody has like a vent, you want to have your emergency equipment on board. Someone has a seizure precautions. You want to have their suction, their O2 like ready to go as well. So just making sure you have emergency equipment. Um, yeah, lots of stuff to keep in mind. So it's a lot easier said than done, to be honest. But at least with the testing, this will be multiple choice, and in that at least that part will be more. It'll come to your head more because it's like, yeah, if I have to do any of these, you're gonna keep emergency supplies on board. So 6 and 7 looks like it is kind of referring to that camp scale. So if somebody is acutely confused, um you're going to be using your acronym here to try to differentiate like what could be happening. So rule out hypoxia and then go from there pretty much. So take someone's like acutely confused, maybe get their vitals, make sure they're not um just lacking an O2 and then kind of go from there. Yeah, basically that's what it is. So if you remember all the way up here, the delirium, that's pretty much what the acronym is here. So that acute confusion kind of goes with that CAM score, which is like a confusion. Let's see what it actually the confusion assessment method. So yeah, it's basically a way to determine all that stuff. So that's where this think acronym is kind of like for delirium. Okay. Some questions on A-line. Okay. Number 8, you're attempting to determine the adequate blood flow prior to having an A-line inserted on your patient. What assessment would indicate inadequate perfusion? So when you're doing your Allen test. Yeah. Yeah, so we went over how, like, and this is the only one that's abnormal, so like it makes sense. You see them like 20 bones. But yeah, so again, if you're doing your Allen test, if you still have pallor in the hand after you let go of the ulnar, it's kind of showing you that the perfusion's not, it's not too good to be put on that radial. So maybe try the other hand, and if that doesn't work, I'm not really sure what you can do there, if I'm being honest. But it doesn't, that part of the thinking doesn't, you're not gonna get tested on it, so it's fine. I think you can, yeah, actually, you could probably get it done femoral. I believe that is a thing, yes. It's just preferred in the radial, but you can get it done in the femoral. Okay, number 9. You're caring for a patient who just had an A-line inserted. What assessments are important? So perfusion, color, cap refill, sure, temperature. And then I'll add on that you want to make sure that it's splinted properly. So having the splint on to keep it consistent position. And that's pretty much it. And then number 10, blood pressure of 87/45. So what is the map? So remember the formula and tell me if this is decent enough. So it requires you to know the formula, requires you to do the know what's normal number. Yeah, so your MAP was 59, so you would do 45 times 2 at the 87. So you get 177. Then you take that divided by 3, you get 59. So the minimum per perfusion, I think with this class they want you to go for minimum 65. And then I think it's minimum 65. Anything under 60 is like really bad, but minimum 65. So it's considered not normal, not adequate enough. Okay, so let's see what else. You're answering a call light for your patient with a newly inserted A-line. Upon entering the room, you note that the A-line has been removed and note a large amount of blood on the bed. What is your first action? Yeah, so someone's bleeding from an arterial, you want to put a lot of pressure on it, like a lot of pressure, not just like literally like you are tourniqueting them with your pressure. Like you have to put a ton of pressure on there or it's gonna keep bleeding and obviously yell for help. Like pressure, yell for help. Okay, so that's good. Okay, so you are caring for a patient with a Swan scans. Their CVP is 1. What does this mean? Yeah, so okay, so Kayla says this is considered hypovolemic. Yeah, so this is a they call it a dry CVP because it's on the lower end. Even if this had been a 2 or a 3, you would still consider this to be closer to hypovolemic. So what's the solution? Jingle mentioned, yeah, you need fluids. So it means that you're dry. So this is dry, therefore you need fluids. So had I changed this number to 2, even though our normal value is 2 to 8, it would still be the same idea. Want more fluids. You want to get this number probably closer to the middle of the 2 to the 8 than anything else. So if it's 2, you still want fluids. If it's 3, you probably still want some fluids. But if it's 1, you definitely want some fluids. Okay? You are attempting to determine the pulmonary wedge pressure. How would this be measured and considerations? So what makes it a wedge pressure? What makes it a wedge pressure? What needs to be done for you to be able to measure this? Yeah, so clamp it. So you need to inflate the balloon on the swan scans. So remember you put the 1.5 mLs into the balloon, get a reading, and then that would be your wedge pressure. And then obviously you undo the balloon. Okay. I think this is my last one. Mechanical ventilator. 14, in caring for your patient with mechanical ventilation, which action is not part of the VAP bundle? And this is select all that apply. So yeah, so everybody's saying A, that's correct. It's not one of the VAP bundles, and there's another one. Yes, so this is what I was saying about like knowing the specifics of it. The ET tube suctioning is a PRN. It's not every 2 hours. Uh, it's like every 2 hours as needed. So as in like not every 2 hours you do it. It's you do it and then in 2 hours you can do it again if needed only. This is implying literally every 2 hours. So that's what I mean with the bat bundle. Know the like the specific frequencies and don't get tricked by stuff like that because they'll try to trick you. Yeah. So think of it like a PRN that's Q2. That's pretty much how you think of it. Does that make sense on what I meant by that? Okay, perfect. And then here's the answers that are on there. I'm gonna save this one, send it over, and then I will get you guys some of the EKG stuff. So I'll send all three of those right now. Oh, I guess I have to save this. Give me 1 second. Okay, so the stuff is all posting now. Take a little bit for it to post, but I guess give it a second because I guess it's taking a bit. I think you guys got sent over just now so I sent over EKG basics, and then I have one that's specifically just the algorithms, and then the week one that we just did, it's still sending over because I guess the upload on this internet's really slow. Okay, I think all three went through. So let's see. I'm okay. Yeah, thank you. And then let me show you guys kind of what's in the. I'll answer questions for any of this stuff here. So on the files you guys got this one right here that we just did. And then I have this basics. So this one is I try to make it as short as possible for both. If it's 10 pages, it's because it has questions and answers. It has questions and answers as well. So it has practice questions for you guys to do. Um, It has this, so this one is a Nursera, yeah. So for the basics, it includes this video from Nursera. I'm not sure how long it is. Maybe it's like 30 minutes. I don't know. I think it's long, but it's a very good video. So I do recommend watching it if you haven't already. It comes with some pictures here, and then some of my general concepts that I wrote down. Uh, as always here, anything important for the class is in yellow. Anything that's maybe extra. I put NCLEX here, but it's actually not. That's what I thought, I guess, before I took the NCLEX. None of this stuff is in the like none of this is on the NCLEX, if I'm being honest. Like it's just extra info. Um, yeah. Critical care is pretty much not on the NCLEX, like at all. But let's see. Yeah. So here it'll kind of be this section right here is just kind of like things to look at. So you're gonna be checking kind of your R to R. So if you had like this line right here, you're checking your R to R. Is it regular or irregular? Right? You're checking to make sure there's a P before every QRS. So there's a P here, P here. You're going to be checking the length of your P wave, your PR interval. So you're going to be checking your PR interval to look for any AV blocks, checking for fibrillations or flutters. So honestly, like when I had to read EKGs at work, it's literally at work it would literally just be like I would literally just look for the regularity of the strip to see if there's like a sinus arrhythmia or something. And then I would just look at the P wave and the QRS. So if the if the PR interval rather, sorry, if the PR interval is more than 0.2 seconds, it's a first degree AB block. And if their QRS, meaning how wide their QRS is, if it's too wide, it's a bundle branch block, but you don't have to know the bundle branch block here for this class, but that's pretty much all I would have to do. It would just be, is it regular? Okay, cool. Is there an AV block? Is there a bundle branch block. Okay, no. Okay, there we go. It's normal sinus rhythm. Or maybe you'll have a first degree AV block. Those were the most common ones I see. I see normal sinus, bundle branch block, first degree AV block. I have seen a few second degree, but I've seen some sinus arrhythmia, but that was pretty much it for the most part. So in this class, the main thing you're going to be doing is checking the R to R. If there's a P before every QRS, the PR interval, looking for flutters or little things like that. And then it's just going to be interpreting the different like specific rhythms and like what to do about it. So here the things I really highlighted is the PR interval. So anything bigger than 0.2 seconds or 5 small squares is a first degree AV block. Well, it could be a second degree AV block if it comes with the other things, but it's some sort of AV block. The QRS, which is this spike here, it should be less than 0.12 seconds. Anything higher than that is a bundle branch block. Slash some sort of issue with the ventricular. The QT interval is basically from here to the end of the T wave. That should be less than 0.44 seconds. You probably will not see anything like that on your test. Though, if I'm being honest, the only thing that would be like for Tersatz points, but that will not even look remotely like it will look very obviously. I guess specifically having an elongated QT interval can lead to Tersatz points. So I guess it could just look like this with a long PR interval. So this line right here would be a little bit bigger. The PR interval has to be less than 1 big box. Yes. So either less than 5 small squares or less than 1 big square. Because 1 big square is made up of 5 small squares. Yeah. But yeah, I have all this other information. Something else for you to know is fast and symptomatic should be a synchronized cardioversion. If you have these, and these are the only rhythms right here that you can do the fibrillation on, which is the pulseless VTach or your ventricular fibrillation. Anything else, and then you're not going to be doing a shock. You're not going to be doing a defibrillation. You're going to be doing a synchronized cardioversion if it's fast or symptomatic. So again, from here, the main thing you're looking at is your R to R, checking for regularity. So I'll highlight that. Checking for your PR interval. This one's really it's not tested on, so I'm just gonna add it here. Looking for how wide this QRS is. And then I would say also you're looking for the heart rate to determine if you're tachy, et cetera, all that stuff. And there's definitely a lot of other rhythms. So if you're doing some of these practice, you'll see like a junctional rhythm. A junctional, otherwise known as an escape rhythm, is kind of like when the main things that control your heart rate are no longer working. So instead of your SA node controlling your heart rate, it could be it'll be your AV node doing it. Or if that doesn't work either, then you'll have your idioventricular rhythm, which is your Purkinje fibers are the ones doing it. But all of that is more like you took like an EKG class, like an actual EKG class to get a certification so that you can read you can read strips at work, but that's not for this class. So this is just superficial basic. Okay. So the main thing they're gonna really test you on is gonna be the telling apart normal sinus rhythm from AV blocks as well as like SVT and ventricular fibrillation, asystole. Those are like the ones they'll test you on. They won't test you on some of like the weirder ones. Okay. And if I recall, for your first few, like you will not have any AV block other than first degree AV block until your final. Your final is fair game, but for your, if I recall, so I there's no way they changed it, but yeah, Jim will tell you anyway. So I think he did like directly tell us this. There will not be an AV block other than first degree AV block up until the final, pretty much. So don't like gaslight yourself. Um, okay. And then this is just like I think I'll just read through everything and then the questions I'll leave to you guys. But yeah, so some of the things like let's say you have an unconscious patient. Some of this is basically like your ACLS or your BLS even. It's you try to wake them up, you go up to them and be like, and be like, "Are you okay? Are you okay? Someone call 911 and get an AED and then check their carotid pulse. If there is no pulse, you're going to be doing CPR. And here's some of the guidelines for it. Something that they want you to know is that your compressions are going to be between 100 to 120. So that's something that I guess changed within I don't know how long ago. A couple of years back, it used to be just I think 100 plus, but now specifically they want 100 to 120. Okay, and that will you'll just trust me. You'll need to know this. Okay, you'll need to know it's 100 to 120. Trust. And then you'll get your AED, hook that up, and then try to get an analysis of the rhythm. And when you are analyzing the rhythm, you don't do compression so you can get an accurate reading. The AED will tell you if shock is advised, in which case you go ahead and do the shock as quickly as possible if the shock is advised. So again, the shock will only be advised on pulseless ventricular tachycardia and on ventricular fibrillation. If shock is not advised, then you just go on with the rest of your algorithm, which is just in which case it would be either a pulseless electrical activity or asystole, because if they, yeah, because you can't shock those. So you can't shock those. So the reason why is because there's nothing to defibrillate. There's already no rhythm, so there's nothing to shock or fix. So that part of the algorithm is just compressions and epinephrine. On the other side of the algorithm, where you do have shock being advised, then you get the shock going, you clear everyone, make sure people are actually clear, go ahead and do the shock, and then you restart your, you'll be restarting your compressions, and then you will be alternating between epinephrine and amiodarone, and then also doing shocks as advised. So you'll do your you'll do your CPR break, do analysis. If shock is advised, you shock and then continue CPR. And then of course your goal is to get ROSC, which is return of spontaneous circulation. And with us, he didn't go over it, but you'll need to know part of it. So what to do after return of spontaneous circulation. If they're still comatose, here are some of the things that I want you to know. I want you to know that there is such that they will need to be maintained at a certain temperature just to keep basically just a cool temperature so that the brain is kind of to cool down the brain, let it work less hard. So yeah, slow down your overall metabolic function to kind of allow your body to rest afterwards. You're gonna do a CT of the head, EEG, which is monitoring the electrical of the brain, O2 and fluids as needed for stabilization. But these are the things I want you to know, because you may have to know it. Oh, I don't know how to say that. Yeah. But that's pretty much that. Here I have some general interventions, um, like chronic ones. So some of the things that you will need to know is kind of like your pacemaker and education. So pacemakers are used for people with very bad bradycardia, usually due to some sort of AV block. People with AFib can, if it's really bad, uncontrolled AFib, they might need a pacemaker. Sick sinus syndrome, which I didn't really talk about because it's extra info, but that's essentially a condition where your body alternates between fast and slow heart rates, as well as irregular heart rhythms. And some of your education that you're gonna want is that they should not be submerging the pacemaker. They should not be taking MRIs because the pacemaker is magnetic, and they will not have a fun time in there. They will not survive. Avoid some tight clothing. Try to avoid lifting the arm above the shoulder on the side that got the pacemaker, which is your heart, so the left side. And after insertion, you're assessing for bleeding, infection, all that stuff that makes sense. You're making sure that your pacemaker settings are actually accurate. Another thing is an AICD, which is basically an automatic implantable defibrillator slash cardio converter. So it's something that they can detect a uh shockable rhythm or a rhythm that requires synchronized cardioversion, and it will automatically do that for you if it detects it. And then some other things for chronic would be people with AFib. They could be on Coumadin, or they might be on amiodarone and cardizem. And more specifics on the next outline that I posted. So this one is more for your specific interpretation. So it's going to have a picture of each. It's a picture of each rhythm, some of the definitions, and all your interventions. So, for example, your bradycardia, some of your signs and symptoms of symptomatic bradycardia, some of your interventions here. And keep in mind the doses, because you might have questions where the answer choices are, like, let's say you'll have two answer choices being atropine. Um, you'll have two answer choices being atropine, but one of them has 1 milligram as a dose, the other one's like 3 milligrams. So keep in mind that you'll need to know the dose on that one, for example. Yeah, so the atropine, up to 3 doses every 3 to 5 minutes. Atropine's there to increase your heart rate, basically. Yeah, and I have other examples here, like symptomatic tachycardia. I have one for AFib, so they all comes with pictures, the definitions of what they are, what to do. So I have like even like the difference between someone with stable AFib, some of like their long-term Coumadin or Eliquis, other medications they could take. versus unstable. So you have your AFib with fast ventricular rate, or you have your AFib with rapid ventricular rate. Those are just different stages of abnormal fast AFib. And some of the symptoms here, you'll notice that a lot of these signs and symptoms are very, very similar. Even with symptomatic bradycardia, you'll see dizziness, hypothesis. What? I don't think that's the. I don't know what this one's supposed to be. Wonder what it was supposed to be. Hypotension. Yeah, that makes more sense. I was like, what? That's interesting. Yeah, you'll see that it's a lot of the same stuff here. Hypotension, chest pain, altered status, shortness of breath. A lot of the same signs and symptoms for all these heart conditions. So some of the treatment there. So it's all kind of organized for you guys to just kind of be able to look through and study it. So even here, your SVT, if it's stable, you go with like the least invasive, quote unquote. So the vagal response, bearing down, coughing, pursed lip breathing, adenosine. Uh, Kaylin says ice water as well helps. Unstable SVT. Unstable SVT. Uh, this one, fast and symptomatic, synchronized cardioversion. The VTAC, which has like this sawtooth pattern. And again, here's the interventions here. So if you have a pulse still, remember it's a different part of the algorithm. You'll only shock VTAC when it's without a pulse. Otherwise, you're still doing fast and symptomatic. Don't worry so much about this. I don't think this gets tested. It's mostly just knowing when to do synchronized cardioversion, when to do the defibrillation. You should 100% know that it's epinephrine 1 mg. And I think you should probably also know amiodarone is 300 for the pulseless ones. That's that part of the algorithm. Ventricular fibrillation. So same thing here. You see the 1 mg and 300 because these are the two pulseless shockable rhythms. They follow the same algorithm. AV block. So how to read it, like how to tell apart type 1 and type 2 Mobits. But again, you will not get tested on second or third degree up until the final. The premature atrial and premature ventricular complex. So here, with the PACs, the PACs will just look like a PQRST that just came extra early. So here every smiley face is an extra like a fast one. So you see here normally it's like boom, it's normal here S S S S. PACs one came earlier, a little bit earlier, but you see when you actually look at it that the QRS still looks normal for the still looks normal. Something that you might notice is that the P wave looks a little spiked because it's like a spontaneous quick extra beat. So your PAC is like a extra beat, but it's otherwise normal, the PQRST part. And maybe the P wave is slightly peaked, slightly more upright and quick. And then for this one, you'll just worry about correcting the underlying cause. So something that can cause PACs is like too much caffeine, So I think if I recall, my boss, he was telling me that one day when he was a new grad, that he drank so much coffee. I think he accidentally he bought like concentrate, I think of like caffeine concentrate that's meant to be like diluted. And he accidentally drank like two of those by accident, and he was like he was not he was going through it. He had to go to the ER. So yeah, caffeine can cause all this different stuff, and your PACs can lead to like right here, frequent PACs can lead to like an AFib or it can lead to a SVT. So he was having a lot of these symptomatics, the symptomatic sweating, the diaphoresis, the heart beating out of his chest, shortness of breath, chest pain. He was having all of that. Yeah, I made this one. Yeah, that's how I studied it basically. I think it's easiest when you just take everything and just put it down. So this is a document I made for myself just to have it all in one place. Yep. And then the PVCs, the main thing you'll see, so PACs is the atrial complex. So it starts with the atrial and it'll have the atrial, which is the P wave, and then the QRS. This one's just the ventricles popping off. So this one will not come with a P wave. This one will just be the QRS because QRS is the ventricle electrical activity, while um, the atrial is the P wave side. So because this is only is a PVC is ventricular complex, you will not see a P wave because it's just the ventricle having that extra beat. So here you see, let's just ignore this part here for now, is a P wave, QRS, T wave, and then you see the PVC right here. And one of the things that you'll note is that this QRS is actually upside down right here. Uh, so a lot your PVCs, another way to tell them apart is that you will see it will be wide. It will be a QRS that looks like it came out of like it's out of rhythm. It's out of rhythm. A QRS that's out of rhythm, it'll be wide. So you can see here that it's wide. And it will have a T wave that is going the opposite direction of whichever way the ventricular wave went. So what does that mean? You see this PVC, the QRS is down, so the T wave will be up. Depending on where you're viewing it from, you can have this the PVC, the QRS will go up, and then the T wave will go down, will be inverted. So let's see if I can find one. PVC with upright QRS. Let's see if that works. Yeah, so right here, this one's a good picture. Um, yeah, right here. So here you have a P wave, your QRS, T wave. Then you have the sudden PVC. So again, there's no P wave before this QRS. The QRS itself is very wide, as you can see. And this PVC, the QRS is upright, so the T wave is inverted instead. While over here, the QRS was upside down, so the T wave is upright. Do you see that? So that's another way to tell it apart. So the PVCs will have no P wave, the QRS will be very wide, and the T wave will be the opposite direction. So here you can have a second picture. So I'll actually include that in here and repost it for you guys. Unless I already did. Oh, I guess I already did. Here's this picture has the same thing. It has upright QRS, inverted T wave. So those are how you determine it. So right here I wrote it down. The QRS appears earlier than the expected rate, and again, there's no P wave, unlike a PAC, which is almost like just like an extra like it just looks like a normal PQRST that came a little bit earlier. So wide QRS, T wave in the opposite direction. And one of the things about the PVCs that if you kind of take a look at it, if you had a bunch of these next to each other, it would start to look like a VTAC, right? So multiple PVCs in a row, PVCs can lead to VTAC. And I believe it's more than, I feel like it's more than two in a row is considered a form of VTAC. So you have what's called sustained versus non-sustained VTAC. Sustained VTAC sustained meaning, it's consistent. That's where you have um, this sawtooth pattern, sustained, because it's constant. It's constantly like this versus non-sustained VTAC. And you don't have to know the difference between, you don't have to know the specifics of it. But this is just to add a little bit of context. You'll see you have non-sustained VTAC, which is basically like normal rhythm and then uh bouts of VTAC, wherever it is. Huh. There we go. This one's better. Like, well, you'll have like instances of normal, normal, VTAC, 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 back to normal, VTAC, VTAC, VTAC. So that is non-sustained VTAC. But technically, this is basically like 1, 2, 3, 4 PVCs in a row. So more than 2 PVCs in a row is considered a VTAC. So if someone is having a lot of PVCs, the application of that knowledge that they're having a lot of PVCs is the knowledge that it could become a VTAC. Does that make sense? So like what is the purpose of, because people can have PVCs and they can be fine, right? But if they're having a lot of PVCs, it can go into VTAC. That's the application of it. That's what you do with that knowledge, basically. And then the last one's asystole. The only thing I'll say about the asystole is a flat line. Is even though it's a flat line, it's not always like 100, like a full, like you could have like a small little tick. So let's take a look at some asystole. So this is where people can get a little off put by. So this is directly from the ACLS website. Some people see this little line right here, this little like slight movement. Like this is not like a completely flat line, right? It's not entirely flat. This is still asystole. So some people on the test, they might accidentally put fine ventricular tachycardia here, or maybe in the option choices they'll be between asystole or VTAC, because there is such thing as BFib, sorry. There is such thing as fine ventricular BFib, which can get confused with the asystole. So that's where that might be like a question, that might be like a quote unquote freebie, but then it's actually like asystole. So that can be kind of hard to tell if I'm being completely honest, depending on how like it can be pretty difficult to tell. This one's, for example, very difficult to tell apart from asystole. But all I will say is that on your test, it will be obvious in terms of, yeah, it looks almost the same. Yeah, they will make it obvious. So, and what I mean by that is that if it is a B fib, it will be it will be pronounced. Okay, it will be pronounced. So so let's just say on the test, oh, this is Sarah. On the test, if you get this line right here, this could be, they might put this as asystole as the answer, because if they want the answer to be ventricular fibrillation, they will make it more pronounced. Okay, they will not make it. They try not to make it too difficult to tell apart. So if you see a line that kind of looks like this, it would be asystole because they will want you to be able to tell it apart. So they will make it obvious. So if it's supposed to be a B-fib, it will be more pronounced than that, if that makes sense. So again, asystole doesn't have to be a pure flat line. It can have like a small, tiny little things going on here. Some of that is artifacting, but if they want it to be a ventricular fibrillation, they will make it look like a ventricular fibrillation. And then there's a little bit on stress test, which isn't too much. It's just stress test. You've probably seen it for people with people having like angina and stuff. They'll do like a stress test to see how their heart reacts to stress. So they'll either have them on a treadmill, or more likely they'll give them a chemical to kind of simulate it, and then do a EKG with with an echo just to see how that goes for them. So some of the indications for that are listed here, and some of the contraindications are listed here. So if someone is unstable, right? If someone's unstable, you're not gonna put more stress on them. That's pretty much it. If they're stable, but they've been having some like intermittent angina, they'll do a stress test. If they've been unstable, they'll do, they'll focus more on the labs and try to go from there, stabilize them first before you put them on a stress test. And that's kind of like, obviously, like if someone's having all of these, that's emergency. All of these right here are emergencies. Like, right? So it makes sense that you would not put them through a stress test, right? So it's only when they're more stable that you'll do that so that you can find out more about their condition. Okay. Is there any questions? Because I know I went through this pretty quickly, and one of the tutors, I'm not sure if I'll be doing this one this week because I think since there's 4 of us actually for you guys, we'll probably be like going on and off every other week, I'm guessing. But that's pretty much that. I'll stop recording.